Hello, this is Jaya Pichika, internal medicine second year resident at the University of Texas Health Science Center at Tyler and residency program at Christus Good Shepherd Medical Center in Longview. Today I am presenting an abstract on COVID glomerulopathy, an emerging entity. Is it the new HIVAN? During the last 2 years, COVID 19, an infectious disease caused by severe acute respiratory syndrome, has been spreading across the globe. Few initial case reports showed AKI in up to 9% of patients with COVID 19 with acute tubular injury as underlying pathophysiological mechanism. However, subsequent studies noted up to 15% prevalence of kidney injury, with hematuria and proteinuria observed at 26% and 44% respectively. Today, we present a case of COVID 19 patient who presented with anasarca and proteinuria secondary to COVID related glomerulopathy. Patient is a 30-year-old Hispanic male with no past medical history, presented with dyspnea, abdominal pain, bilateral lower extremity edema that had been worsening for 4 weeks. Before the onset of symptoms, patient experienced a self-limiting upper respiratory tract infection. He tested positive for COVID 6 days before the day of presentation. Physical exam, there was anasarca, reduced breath sounds bilaterally, ascites, and 3+ pitting edema of legs. Labs showed BUN of 36, serum creatinine of 1.32, total body protein of 4.6, and albumin of 0.4. Urine analysis showed cloudy urine with large protein, large blood, and moderate amount of RBC. CT of chest was remarkable for bilateral infiltrates consistent with pneumonia, bilateral pleural effusions, and abdominal ascites. He was admitted for acute hypoxic respiratory failure secondary to COVID pneumonia with AKI in the setting of severe nephrotic range proteinuria. He was started on decadron, azithromycin, rosafin, Lasix, and supplemental oxygen. Over the course of next 2 days, his AKI resolved. A CT-guided renal biopsy was done and it showed collapsing glomerulopathy, ATN, mild arteriosclerosis, mild interstitial fibrosis, and tubular atrophy. He was started on lisinopril and statins. His edema and oxygen requirements improved and he was discharged home with supplemental oxygen. Recent studies showed that the mechanism of AKI with SARS-CoV-2 infection is variable and not well understood. Santoriello and others performed postmortem kidney biopsies on 42 patients and found that acute tubular injury was the main pathologic finding correlating with a history of AKI. Kudos and others performed kidney biopsies on 17 patients with COVID-19 infection, of which 29% had collapsing FSGS as primary diagnosis for AKI and 70% had acute tubular injury seen in pathology. Our patient was diagnosed with mild disease, so after literature review, in this setting he was started on conservative non-immunosuppressive treatment including RAS blockade and statins. Collapsing FSGS is a known complication of other viral infections, in particular HIV, as well as CMV, parvovirus, B19, and pamidron use. Also, APOL1 genotype is highly associated with collapsing glomerulopathy. Collapsing FSGS is an under-recognized cause for renal failure associated with SARS-CoV infection and has a poor prognosis. Thus, we suggest there should be a low threshold to suspect and biopsy collapsing FSGS in patients with high-grade proteinuria, AKI, nephrotic syndrome, and African descent patients. Further research is warranted to provide data for management and outcomes. Thank you.